Welcome to the Ethicon-sponsored lunch symposium focused on innovating the future of coronary surgery. We're thankful to Ethicon for their support of this 10th annual International Coronary sponsoring this lunch symposium. Please grab a lunch, come to the front, don't sit at the far back. Please come and join the program here. We're looking to have a very interactive program. I'd like to invite Dr. Arthur Martella and Dr. Omar Mahi to the podium now to join me, and we'll get started with the program. Dr. Martella is Chief of Cardiothoracic Surgery at Riverside Regional Medical Center in the United States. With over 20 years of experience, he's been dedicated to advancing non-sternotomy approaches for coronary surgery. He's a strong advocate for incorporating patient blood management strategies as a critical component of a successful minimally invasive program. And this fits very well with the theme for this session, which is to enhance outcomes in coronary surgery, especially addressing frailty and outcomes in women, and advancing multi-arterial grafting. We're going to have two presentations, and I hope those will both be accompanied by a discussion and conversation and questions from our attendees during this lunch session. So Dr. Arthur Martella.
Thank you, and thank you to Ethicon J&J for the opportunity. These are my disclosures. I'm going to focus a fair amount on hybrid coronary revascularization. It's been a strong interest of mine, and I think it's hopefully a growing interest around the world and certainly in the United States. I think it's really felt to be the application of the best of both worlds, minimally invasive coronary surgery and PCI. I think it can take on many different forms. Mid-cab lima to the LAD for single vessel disease, for two vessel disease, potentially a mid-cab lima and then PCI of the other vessel. Two vessel and three vessel disease, sometimes with mid-cab bema and PCI, and multi-vessel mid-cab with a lima, and then ultimately T-cab. I think there's been a number of studies that have, over the last few years, supported a hybrid approach to coronary surgery. And there's certainly, in this study, certainly showed that the risk of MACE and other complications was certainly equal and probably better than open coronary surgery. In the last year, I would say, both the EACTS and the STS have put out consensus statements related to hybrid coronary revascularization, both of which were positive, supporting the approach. And I think the basis for hybrid coronary surgery is that what we probably do best is providing that lima to the LAD, which probably in many patients supplies up to 50% of the blood supply to the left ventricle. The lima is also felt to be really the best way to revascularize the anterior wall, as we all know. Cabbage versus PCI in those non-LAD vessels, particularly if we're placing vein grafts on those vessels, is probably comparable, and certainly the results for our vein grafts versus PCI are potentially equal, depending on the anatomy. So we have adopted a sternal sparing procedure utilizing the robotic approach, a robotic platform, and hopefully to capitalize on the non-sternotomy approach and the lima to the LAD. I think the benefits are that we're not manipulating the aorta, we're reducing transfusions, no bypass is most of the time utilized, and with much shorter length of stay. The downsides, the disadvantages are certainly, though, that these patients frequently need two procedures. There's single lung ventilation involved, and there's management of the plavix with potential for bleeding related to the procedure. In addition to that, there is this potential for three-vessel disease creep, of what I refer to, and that's where patients are being referred with multi-vessel disease for a hybrid approach. And I think there's this ongoing sort of pushback that we have to make sure that we're not compromising what the patient needs. If they need multi-arterial grafting through a sternotomy, then I think we have to push back on the multi-vessel PCI with robotic lima. We've also been trying to utilize the hybrid suite to not just manage the lima to the LAD, but then also to check our lima and then proceed with the PCI in a one-stage procedure. I think part of this is having a high-functioning team. I think we have spent a lot of time looking at these procedures. I think one of the advantages of a hybrid approach is that it brings the cardiologist, the interventional cardiologist, and the cardiac surgeons together to discuss these procedures. I think it has been one of the advantages of TAVR, and I think now it's one of the advantages of the hybrid coronary surgery realm. I think it's important that we review our STS risks. Certainly these patients, if they're a high risk for open heart surgery, for open CABG, they're probably going to be similar risk for that non-sternotomy approach also. So we certainly have to select our case as well. I think one of the problems with any robotic approach is that we're no longer at the center of the procedure. We're in a console. We basically have our head buried in the console, and we're not always completely aware of what is happening in the room. So you really need that team to be participating in all aspects of the procedure. I think this has also helped us maintain good outcomes and introduce new technology, rapidly assess it, and then move on if it's not working. Having everybody's input, I think, is critically important. So who do we do first? How do we select which procedure to do first? I think most of the time it's the culprit lesion that we try to manage first. So if there's a high-grade right coronary lesion and a complex LAD lesion that's not as critical, we will usually use the PCI route of the right coronary first and then proceed with the robotic lima to LAD. I think the patient selection is obviously key in these patients, particularly depending on your experience. Obese patients and particularly small stature patients are particularly difficult. They're not, it's not something that can't be done certainly, but there are certainly challenges with those cases. I think the patient that's ideal for the hybrid approach is a patient with multi-vessel disease, ideally two-vessel disease with low complexity. And focal lesions in the left circumflex or right, certainly with then a higher complexity in the LAD, are probably those that are going to fit nicely into the hybrid approach. The LAD that's intramyocardial, calcified, or has a long stented segment is going to be particularly difficult, but again, not impossible. Left main disease in high-risk patients is also an area where we have utilized this approach. We get preoperative CT scans on all our patients. I think for any minimally invasive approach, it's important. You're certainly going to pick up areas that you may not have noticed before. So CT scans looking at the abdominal aorta, thoracic aorta, and the intrathoracic anatomy. I think some of the advantages are the magnification, 3D visualization, there's no tremor, and I think it does set us up for the next stage, which is utilizing the robot for bilateral mammaries, particularly with the Y anastomosis or with a pedicled in situ approach. This is just our setup. Certainly similar to VATS, we utilize CO2 insufflation, but certainly that's not necessary, and lung isolation is not necessary either if the patient's not tolerating it. I think the current landscape of hybrid coronary surgery is improving, particularly with the two studies from the STS and the EACTS, and it's certainly suggesting that early results, 30-day results, are very similar to open heart procedure. I think the risk of transfusions are significantly lower in this group. Ventilator time is significantly lower. We're extubating most of these patients in the operating room. Stroke and AFib are lower, and I think that has to do with the degree of invasiveness and the retained blood that may occur, particularly with open procedures. I think one thing that goes sort of under the radar with some of these procedures is the long-term impact of our blood transfusions, and we know that patients who receive blood have worse short-term and long-term outcomes. And the minimally invasive approach typically has lower transfusion rates, which I think we don't typically focus on. I think it is, though, a strong part of the support for a minimally invasive approach. All patients require chest tubes, but the chest tubes are not always the best at evacuating blood, so we're pretty aggressive about minimizing any retained blood or oozing that's occurring. Most of the chest tubes also are not functional. Even though they look functional, they're not functioning that well, and even within 48 hours, at least a third of them are probably occluded. In addition to that, there's this inflammatory response from that blood in the pericardial space that leads to, I think, the atrial fibrillation that we see more frequently in the open cases. We drain the posterior pericardium on all these cases to help reduce that blood collecting around the pericardial space. I think patients with stable multivessel disease or a stable acute coronary syndrome can benefit from this approach. Totally occluded LADs are obviously the easiest and the ones that are most amenable to this approach, but certainly any patient with two-vessel disease or selected multivessel disease might benefit from this. I think it's important that we focus on IFR guided approaches. I think the outcomes have been shown to be improved when we're utilizing IFR, FFR to guide our grafting. And I think this is particularly important when we're utilizing arterial grafts. I think this is just a depiction of the benefit potentially of patients with a left main that's significant and a LAD that's tight. By putting that lima on the LAD, it does improve the FFR through the left main, supplying the circumflex vessel. And I think that we've utilized this for some mild to moderate left main disease, and particularly in high-risk patients. Antiplatelet therapy in the hybrid coronary arena is an issue, certainly. We try to utilize all the sort of techniques to assess the patient's sensitivity to Plavix particularly, but we don't allow that to keep us from deviating from managing the culprit lesion first. If that's not the LAD, then that's what we do. And utilizing some of these other techniques, we're able to mitigate a lot of that risk of bleeding from the Plavix or Brilinta. I think two-vessel disease with an LAD not amenable to PCI is obviously the case that we are looking for most frequently, and certainly in the early stages of developing a program, it's the direction that you want to head. I think multivessel disease, where there's a conduit concern, can be an issue. I think we've adopted a use of bilateral mammaries for most of our open cases, so those conduits are, for the most part, always available. Multivessel disease with complex LAD disease and poor surgical targets in the circumflex or right is, I think, where sometimes triple vessel disease may benefit. Patients with triple vessel disease where there's really only two potentially graftable vessels may benefit from a hybrid approach. And certainly patients with porcelain aortas or very frail patients may also benefit from this. We use 3 ports. We use lung isolation, but it's not absolutely necessary, and some mild CO2 insufflation. I think the robotic procedure, the docking part of it, should be quick. I think you can manage adhesions very easily and quickly. And even if there's poor lung isolation, it doesn't keep you from proceeding with the operation. I think it's important to get through these parts of the procedure quickly because you want to get to the meat of the operation, and potentially the mammary artery takedown can be difficult. I think most of the time, though, we can do this in a similar amount of time as a open procedure. I think we expose the mammary artery through most of its length initially, and I think this reduces our risk of injury to the mammary artery. And once we've done that, then we skeletonize and take the branches. But I think once you've exposed it, the rest of it becomes just a technical procedure. We utilize most of the time a mid-cab procedure, and we bring our stabilizer and the suction for the stabilizer out through separate port incisions. So we really have nothing through the incision that's interfering with the procedure, and you can sort of see the anastomosis even from a distance there. We use shunts on every case, and we also use a headlamp with a camera. I think this is critically important because I think the team needs to be participating in these procedures. It's very easy for them to be disconnected from what's happening at the field, particularly with these smaller incisions, and I think the camera has helped keep everybody engaged in what's happening. We also use, I think, for these distal anastomoses, we're really trying to get beyond all the proximal and even mid-disease, and the Everpoint 7.0 has been particularly helpful. I think it's a very durable needle, significantly more durable than other 7.0s that we have available. Occasionally, we have to use femoral cannulation, and this is usually for multi-vessel robotic procedures, but I think it's important to have that available, particularly if there's any hemodynamic issues while you're doing the procedure. I will say, though, that those are fairly unusual. Closure of the incision, I think, is particularly important. I think most of the complications from this procedure come from the chest wall itself, bleeding from the chest wall, bleeding from the muscle, and the closure is particularly important. I think we also utilize Stratafix for our muscle layers, and I think this has helped us have a good outcome and closure after the procedure. I think it's important that we really want to have a pleurovac that looks like that at the end of the case. That's not usually our second pleurovac of the day, but we want to have that pleurovac when we show up in the intensive care unit. I think managing bleeding is particularly problematic in these patients because it's not always easy to put an extra suture in, and even applying pressure can be difficult. And again, most of, I think, this bleeding is occurring from the chest wall or your port sites, and then also potentially your mammary bed. This is an example of a delayed bleed from a chest wall bleed, hematoma, which actually happened after the discharge of the patient, but certainly result in a significant amount of morbidity for this patient. We will also utilize a Surgicel snow to the chest wall, particularly in patients who are going to undergo a PCI after the Lima LAD. We've had some patients return with chest wall hematomas from the mammary bed itself. And to the right, obviously the pleural effusion, the hemothorax from drainage, usually from the chest wall, is something that can completely sort of ruin any of the benefits of the robotic approach if you're having patients in the ICU and also requiring additional procedures to drain this blood. We will also utilize Veriseal or Hemoseal after protamine reversal for the chest wall, and we found that very aggressively managing the chest wall has helped us move these patients along quicker. This is just one unusual case that we did, 58-year-old male who had had a CABG ×3 in May with 2 veins and a Lima, and came back to us in September with a anastomotic problem, and there was a fistula of the vein graft of the mammary vein going back to the innominate vein. And so we were able to take a piece of free Rima and take it from the distal Lima to the distal LAD, and then ligate the vein graft. I had never seen that before. The open sternotomy, I think, is really becoming the procedure now for multi-arterial grafting. I think if we're not doing a PCI and Lima LAD with a robotic approach, or bilateral mammaries with a robotic approach, then we're doing multi-arterial grafting through the sternotomy. In conclusion, I think hybrid coronary surgery is hopefully a growing field, a growing area of coronary surgery. I think it's going to become more available for higher-risk patients, and I think this, to me, is the stepping stone to doing multi-vessel robotic procedures and TCAB with multi-vessel bilateral mammary arteries. Thank you.
Thanks for that great presentation, Dr. Martella. Tell me, you made a comment about bleeding being mostly from the chest wall. In my experience with the robotic bypass, it's mostly from the trocar sites, not the IMA harvest bed. How do you deal with or surveil or prevent bleeding from the trocar sites?
I would agree with that. I think we do utilize the camera. We disconnect it from the robot and look at those sites. I think the only time where the chest wall becomes a problem, the actual incision part, is when we have to go through a second interspace. Once in a while, I go through an interspace and we have to either move up or down one, and then we're really causing more chest wall trauma. And I think that's probably where we're going to see more of that bleeding.
Dr. Balke, you've probably put more trocars between more ribs than any other living human. How do you manage trocar bleeding?
Thank you, John. Trocar bleeding is interesting in that we don't see it as much in the TCABs because we don't give a lot of heparin. We ACT about 300 in most patients. And so we don't see it in those cases. We see it in intracardiac cases on the other side of the chest when we're doing robotic mitrals. And we've developed, we actually just published this, or are publishing it, a balloon tamponade type of a procedure that has been done in the past, but we liberalized the use of it. So any robotic arm that drips on a robotic mitral or aortic or whatever we're doing, we basically take that port out at the end, put a balloon Coude catheter, blow it up, tighten it up, and tamponade that arterial bleed at the port site until the protamine is in, and then release it. And we found that that actually brings it down a little bit, the incidence of bleeding and the need to take them back. It's been described, it's done. We used to do it only in really severe cases and take it to the ICU. This is not that. This is intraoperative until the protamine is in, and then take it down. But can I ask a question? First of all, I have two questions, actually, Art. First, congratulations, great talk, and I know you've been doing this for a long time and have a lot of experience, and real-world experience is, I think, the most important thing in this approach. And one of the things, we have a paper coming out on reverse hybrid, and the question of DAPT, and what do you do with the DAPT? I have two patients that are cooking right now. Both of them are physicians that have had extensive stenting of their right coronary in an acute setting with tight proximal LAD lesions, and I think the other one actually has a little bit of left main. And they're on Brilinta. And the conversation between me and their cardiologist is, how long does the Brilinta have to last? Why are they not on Plavix? How am I going to operate on them? Is it a Xience? Is it not a Xience? How long is it, the stent? And it's always a dilemma, and each patient has their own conversation around this. So I like the fact that you have some solutions for hemostasis, because I think as we move forward in this project, we're going to be doing more and more patients on dual antiplatelets. My tradition is to stop it as much as possible and then operate, even if it's a month later. Some cardiologists say a month. Sometimes I'll get a cardiologist who wants to placate me and say, oh, you can take it off after 3 weeks. And I say, no, that's not a good idea. And so I think we have to come up with some kind of guidelines to that, and maybe your experience with Brilinta, Plavix, how long, stent type, maybe target, is it the RCA's CIRC that they stented? and mostly in reverse, because I think in the non-reverse hybrids, it's not an issue. And the second question, which is probably the more important one, is how did you get that needle to go through the brick? That's pretty impressive. Yeah. Thank you.
I had a lot of strength training, yeah. But I actually think, though, that each patient is an individual challenge as far as managing their DAP. And I think, we check P2Y12s and TEGs, and we have an idea of how sensitive, how responsive they are to the Brilinta or the Plavix particularly. And then with other risk factors, do they have renal disease? Do they have, thrombocytopenia to begin with? And then, I think it's kind of a sense for what you think their overall bleeding risk is for the procedure. But I think with utilizing some of these tools, I feel a little more comfortable taking on that patient who's even somewhat sensitive to the Plavix. I think, you have to weigh that against the risk of stopping that early. Or, in some patients, you're being pushed to do the procedure without waiting. And I think having these things available definitely helps.
I like your comment about the EverPoint needle. We call it the EP needle, which, depending upon who's in the room, stands for extra penetration or extra painful case. But the EP needle really can get you out of trouble. It'll sew just about through a brick. We do a lot of endarterectomy, but, there are times when you don't want to do that. You just want to get that graft shown in there, and the EP needle will save your bacon.
I agree. I think particularly when you're trying to get beyond a calcified lesion, sometimes those heel sutures are going into calcified areas. And I think having the needle, which really is durable so that by the time you're done the anastomosis, it's still very, the integrity of that needle tip is still pretty much the same.
Other questions or comments from the group? Super. Thank you very, very much. Ethicon is focused on a global perspective on coronary surgery, and so we have two speakers, one from the Southern Hemisphere. Dr. Omar Mejia is from Sao Paulo, Brazil, both a clinical investigator and busy cardiac surgeon, and he's interested in enhanced recovery programs and training future surgeons in advanced coronary surgical techniques. He's going to talk about innovating the future of coronary surgery. Dr. Omar Mejia.
Thank you. Thank you, Professor Puskas. Thank you, Johnson. Thank you, Susan, Barry, for the opportunity. We have a project from Latin America. Thank you. Well, we are in London. This is our recent Queen trial. It's a randomized multicenter clinical trial to evaluate the patency of no-touch saphenous vein graft versus radial artery graft 1 year after coronary artery bypass grafting in women. We believe that the radial artery, we have a strong sign 1 year after myocardial revascularization surgery in women. Evidence that might guide the state of the art of CABG in women. This is our hypothesis. What is the best second graft for women? This is the question now. We know about the proportion of women is a little bit, is 16.8%. We have problems with anatomy of the women, for example, smaller vessel size, more tortuosity is a problem to correct, to make surgery, to stent, for example, platforms. It is a problem because if possible, we have a bleeding, we have the rupture of tissue. The other problem is underutilization of multiple arterial grafting. But the problem with the ARS trial is in women, we have a lot of complication with increasing risks of external complication. It's a very problem. And we have in this paper, this beautiful paper, we have two grafts possible because it's the better reason, radial artery, and the other is not touch saphenous vein graft. It's potentially, because the patency is a very good. This is the problem of radial artery with transign. It is recovery after 1 year. It knows, certainly. But the touch saphenous vein is a very, very used nowadays. We know about 95% of the patient have a saphenous vein in CAP surgery, in each CAP surgery. But data show greater patency with no touch saphenous veins comparing to saphenous veins is a class 2A recommendation. But the problem is wound infections when you use no touch saphenous vein. This is a modified technique in our hospital. It's an intermittent wound to collect the saphenous vein. But we have a problem with this publication, this presentation in European Society meeting, because the patency is a tendency for no touch is better than conventional veins, but the infection is a big problem. Yeah, the infection is a big problem because it's increasing more or less 2 times. It's a big problem, but we need to worry about long-term patency and not short-term infections. We have this increase, for example, readmission of the patient in the hospital, more or less 5 times. Increase diet of the patient 2 times. Its cost is very high with infection to the hospital. It's 3.5 until 10 billions of dollars, more or less by year, of additional costs in these patients. We have a lot of dispositives to save, to use, to better, to save bleedings in the patients with risk of bleeding or reoperation, for example, Surgicel, Surgiflow, Everpoint, and others. But the surgical risk can get even worse because we have frailty patients. This is the other project in our center, the impact of coronary artery bypass grafting in women frailty is increase the risk, certainly. But the frailty patients have a more risk in outcomes. Readmission, mortality, infections, increase the risk of pre-frail patients, increase the risk more or less 1.5 and 2.3. But in frail patients, increase more, 2.0 risk of operative mortality and 3.0 risk of midterm mortality. But what about the impact of CABG in women's frailty? Because frailty is a consequence of cardiomyopathy. This is our other question is presented this morning to evaluate the impact of CABG on patient frailty criteria and compare between women and men. This is our design. We are able to enrollment 272 patients to this analysis with CABG indication, 60 years old or more, 2 or more frailty criteria by frailty scale, and intervention on pump and off pump. The elements is weight loss, physical activity level, gait speed, grip strength, and self-reported fatigue. In women, it's 88 patients, men is 184. We repeat the frailty scale 6 months until 1 year after. In men, we have a difference. Is my point? Yes. In men, we have a difference after surgery. We can reduce frailty patients to a very important change. We appear in robust patients in 6 1 year, and women is similar. We have a gain in physiological robust patients between men and women, but best results in men. When you compare men and women before, no difference. But after the surgery, men is more or less twice more robust patients in compared with women. But it's the tissue of this patient is more complex. Calcifying tissue, for example, is a thin wall, the coronary vessels in women. It's very important to care with the bleeding in this tissue. It's very important. But in conclusion, in this analysis, in this project, is that CAPS significantly reduced frailty in both in men and women. The surgery improved physical activity levels, walking speed, and fatigue, with men showing particularly pronounced benefits compared to women. It is in our project now to grow up our program mix in Latin America. It's similar to achieve the results of Arthur. We need to a platform database because we need to grow up sustaining and scalability in Latin America with better outcomes. We have a lot of variables influence in our outcomes in this new way of cardiac surgery in Latin America. We have a lot of important aspects. For example, adequate instruments, adequate dispositive for a better outcomes, direct training in our team in different sites in Latin America. We have a partnership with Professor Thorsten from Jena to come into Sao Paulo to help in our program. IRAX is very important. Is the platform, is the pathway to better results happening. We need data. We need data because it's very important, this platform, to a true grow up. And it's very important we launch in Latin America to include patients in as a ludic a platform to friendly to the. We need to put the data in analyze after them. We have a very approach, a very we have a put of data of the patient. The more important is the safe information to know the difficult to put in the platform is very problem because our platform is very friendly. We have a need to analyze the outcomes, for example, and it's positive with the outcomes, bleeding, infection is very important. We have a need to grow up, mix in the better manner with data. Thank you very much.
Terrific presentation, Dr. Mejia, and again, I congratulate Ethicon for having representatives of both the North and Southern hemispheres. That's great. We are the International Coronary Congress, and Ethicon is one of our most important sponsors, J&J, and they are also have a global perspective on this problem of cardiovascular disease. You talk a lot about frailty, the differences between men and women, the benefit that coronary bypass has on improving frailty, but also the risk that frailty brings to the operating table and the risk of mortality or morbidity after surgery. What is the role in your practice of what we call prehab, prehabilitation, trying to reduce frailty and improve robustness of the patient before the operation? albeit that's limited by, the fact that the heart is not yet revascularized. We can't put these people on very vigorous exercise programs, but is there an opportunity there, or what are your thoughts about prehab?
Thank you. Excellent question. We have in this moment, because we finished the frailty project, in this moment we implement the ERAS protocol in this patient with rehabilitation, one more 30 days before the surgery, with nutritional program, with physiological, psychological program, and to improve the outcomes after cardiac surgery in this patient. This is a new tool in our scenario.
Dr. Dunst.
Yes, Omar, great presentation, and I would like to sort of congratulate you on this because, you are the first to show that if you operate on a patient that is frail, frailty goes down. So you improve patients that have a frail status, and the current perception is that we are not operating on these patients because they're frail. And so that is, I think, is a very important paper, and we've talked about this, but I think that is one thing that is important to state here one more time, that people realize that, the importance of this. And so but the other thing I wanted to ask you is, it's one of those things that always comes when we talk about surgery in women. There obviously is so much more difficult. And then we also accept that the fully arterial revascularization rate is low, and that's just a given because it's a woman. And I think that's I have the feeling that's the justification for taking a vein. And I was invited to write an editorial for the European Heart Journal where outcomes from the Australian and New Zealand registry was published. And they have also the same thing. They have less arterial grafting in women, but only a small fraction. But the entire total rate of arterial grafting in men and women is around 50%. So I wonder what's the difference between Australia and all the other continents, because the rate in Europe and in the US are not 50%. And then, the difficulty may be there, but the Australians and New Zealanders, they show us that it can be done much, much better at a much higher rate, unless the women in Australia are much bigger and all the factors don't apply. I don't know. So what is your take on this?
Well, thank you, Professor Thorsten. I think in the next year we have our trial to results and publish to a series of sub-analysis in women in the other scenarios. In relation to the Australian or Latin America, for example, I think it's data. Data is a difficulty in Latin America in this moment. We have, if we cannot identify where the problems in Latin America exist, it's difficult to build a strategy to correct these problems.
You've made a great point, Torsten. The Australians, like the Japanese, have had historically a much higher utilization of multi-arterial grafting, whether it be with the radial artery or bilateral mammaries. It's been both in Australia, more double mammaries in Japan. Obviously, the physique of the average Japanese woman is not probably as robust as the average German or French woman, not as big. But the Japanese have had great leadership. The Japanese Association for Coronary Artery Surgery predates the International Society by more than a decade. And I think that they've also faced an earlier onslaught of multivessel PCI. The PCI to CABG ratios passed 10 and then passed 20 in Japan before any other country. And the Japanese surgeons quickly figured out that they were literally out of business if they did not evolve. So they had good leadership and a pressing force towards evolution. Now, evolution, as we all know, is a little odd in Australia too. things have evolved to, they have marsupials and a lot of poisonous animals and the like. But the surgeons have also evolved differently than in North America or Europe. And I think it also boils down to great leadership. Brian Buxton, Jim Statulis, people like that. And I think that they've had a fairly competitive environment. I don't know that it's so much from the cardiologists as from each other. They have a very competitive system. And so the evolution among surgeons has been towards technical advancement. But I have no intimate knowledge of Australian women, but I don't think they're small. They appear to be average in terms of their Caucasian size is similar to Germans or French, and bigger than Japanese. But still, the Japanese are ahead of the Australians, who are way ahead of the Europeans and North Americans in terms of arterial grafting.
Well, but that means that if we come from the perspective of the International Society for Coronary Artery Surgery, then we just have to wait for another 100 years.
Well, we have to push the evolution, and that's why the society was founded, right? We want to take responsibility for leading improvement in coronary revascularization globally, and we respect and want to mimic those countries and organizations that have gone before us and proven that it can be done.
Hi, sorry, excuse me, Rakesh Arora, University Hospitals in Cleveland. Omar, really great talk. Again, I'm going to fixate on frailty, obviously, since that's also my bag. You know, when we looked at this before, it was sort of a third and a third and a third. Third got better, third stayed the same, third got worse post-surgery. And I think what we didn't do, and this was in a pre-ERAS era, that I didn't divide between men and women. I think that's a really fascinating finding. So to combine the two questions then that you've heard, so there's something different about women in terms of phenotype. And is the money, when you look at where the frailty elements remain post-operatively, is it in the preoperative phase that there's opportunities for prehab, or is it more the intraoperative phase in terms of how they're being revascularized and managed that will have the bigger bang for the buck, do you think, going forward based on your randomized trial?
Thank you, Rakesh. Existe you're published about the years in frailty. Because I think it's the same. The rehabilitation, the preoperative out of hospital is a better moment to the opportunity to prepare the patient in physical activity and physiological. I think but it's a little bit in our scenario, cardiac surgery. I think in the world, we need to prepare into the patients to the cardiac surgery. It's similar to a marathon, for example, yeah. But it's very important to include this project, rehabilitation in our pathway. Thank you.
I will point out that we have a terrific ERAS, a coronary ERAS program, which will be the first 2 hours of plenary programming tomorrow morning from 8:30 to 10:30 here in this hall. So we're looking forward to that. And it certainly dovetails into this program that J&J has put together here for this lunch symposia, and which is consistent with the themes that we've been discussing for our entire meeting. To advance the quality of care, we've got to begin pre-op, intra-op, post-op. It's got to include arterial grafting. It's got to include management of atrial fibrillation. It should include quality assessment of grafts, and we're going to talk about that in the next session as well. Other questions from the floor? Any comment about bleeding in females? Do you think women have more bleeding problems than men, or is it just a matter that they tend to begin more anemic and just a smaller amount of blood loss leads to more transfusion? Because clearly we see that females having coronary bypass surgery generally have a higher likelihood of blood transfusion and more blood transfusion than males. What are your thoughts, and what should we be doing about it?
In our hospital, more or less, we have 5% of bleeding, or operation for bleeding. In women, more or less 7%. In men, more or less 3% of bleeding in high-risk patients. This is our data.
are there any particular intraoperative strategies you have for mitigating against that risk of significant blood loss in women?
Yes, we use as new niche, Surgicel new niche in the sternum. When you open the sternum, for example, in frailty patient is important. We use cell saver, is a hiccup to the bleeding of the patient. We use, in this moment, we are preoperative identification of anemia in our patients to correct in ambulatory site.
Yep.
But in off-pumpy is we made more or less 80% of patients, in CAPS patients, off-pumpy surgery.
We've been impressed that particularly the older women tend to have a rather cavitary bone marrow in the sternum, so that the cortical bone is relatively strong, but the cancellous bone, the central portion, can be rather vacuolated or almost missing in some patients. So you have these big venous sinusoids that can ooze blood through the whole case. I've been a fan of shoving vancomycin paste into the bone marrow on both sides at the beginning and then again at the end of the operation. And it tamponades for bleeding, and I think it greatly reduces the risk of sternal wound healing problems, which are more common in females than males. So that's something that I've felt was very helpful. On the very severely sort of empty or hollow bone marrow, I will take a strip of gel foam, and just before pulling the sternal wires or sternal tapes closed, sandwich that on top of the vancomycin in the bone marrow to achieve some physical tamponade and reduce bleeding from the sternum. I think the sternum is the one area of bleeding that you can't perfectly prevent. You can prevent perfectly any bleeding from the anastomoses or the conduits or the cannulation sites. Even the harvest sites, if you are really meticulous. But once you pull the sternum shut, you don't really know what's going to happen to the bone marrow. And so I've kind of been a fan of proactively approaching that to mitigate against later bleeding, which, as you know, tends to occur beginning an hour or so after the patient gets to the ICU. Any other thoughts, comments, special techniques for operating on women or frail patients, other than avoiding a sternotomy entirely?
I'm not going to say that, okay?
Okay.
First of all, you got to avoid that. No, there's a technique, and since we're talking about with the support of J&J here in Ethicon and suturing, when I was doing a lot of sternotomies and my partners, we would never run the stitch in the subxiphoid fascia. And in women who might be more at risk for a dehiscence down there, is there any thoughts about that as a technique, using an interrupted suture to really bring that down and not consider it part of the continuous stitching of the fascia down all the way to the bottom?
I actually do that for all obese patients or frail patients, the first stitch or two, or figure of 8 interrupted stitches in the lower xiphoid fascia, and then run it up the top.
Because I think that makes a difference in terms of preventing some of these maldehiscences and epigastric hernias, which I think are a problem, can be a problem.
For the woman with large breasts, gravity is your enemy.
Right.
And so there are various binders or special brassieres garments that we have them actually fitted for, and nurse practitioners apply them so that we don't have weight pulling on that incision. And then those patients are instructed to be wearing that at home as well. Compliance is imperfect, but I think it makes a difference. Okay. Dr. Hiro Arai.
Hi, this is Dr. Arai from Tokyo. Thank you for Dr. Pascas for referring the Japanese situation. And I'd like to introduce the tendency of Japanese selection of the graft in Japan right now. We mainly use a bilateral ITA instead of radial artery, but we use for the left side of the coronary arteries. And the difficulty is right coronary. So it's the same as the PCI, especially the austere lesion of the PCI or the right coronary is not good result, actually. So I think that recently we prefer to use a non-touch surface vein graft for the right coronary artery. 20 years ago, we, as an average, almost 25% of the usage of the GEA for the right coronary artery, but it was drastically decreased right now, about only 5 to 6% of the patient we selectively use GEA. The reason is that if it's a moderate stenosis or eyeballing if it's stenosed right coronary artery, but if it's a more than 1 millimeter minimal lumen diameter, the GEA will not work. So we selectively use GEA. We still use GEA, but completely occlusion or more than 90% of stenosis. We very selectively use GEA. It works because the cardiologist in Japan is very, usually they perform the postoperative Chine angiogram and their follow-up is very strict. So if we fail, we lose the patient. So that's another reason that the Japan, the multi-artery grafting is increasing. So,
well, that's a very interesting comment, Professor Arai. And many people in the audience may not know this, but it is routine in Japan that patients will have a coronary angiogram before hospital discharge after coronary bypass surgery. And that's actually reimbursed, so the cardiologists do it. So just think about that. Basically, every surgeon has quality control for every graft they do. We don't have that anywhere else in the world. And that drives rapid improvement for obvious reasons. You actually have a feedback loop and you have a powerful incentive. And of course, they see whether it's an artery, whether it's a vein, they have a look at varicose vein grafts compared to a beautiful right ITA. And so this, I think, is another contributor to the more rapid evolution of coronary surgery in Japan than in most parts of the world.
and also I'd like to comment the interoperative graft assessment, transit time flometry, it was covered by the government insurance for each case.
Yeah.
So almost all the institutes in Japan, we perform a TTFM assessment. And recently, the epicardial echo scanning is increasing for the number. So otherwise, we will be killed by the cardiologist. So
Fascinating. So use of the intraoperative graft assessment, which is also worldwide used in a small minority of patients, is the norm for patients in Japan for two reasons. It's funded by the government, and the surgeon has a strong incentive to make sure the grafts are good before they leave the OR because they know the cardiologist who referred the patient will be doing a cath before that patient leaves the hospital. So there's a powerful incentive. So you see that cardiac surgeons evolve based on their environmental influences like any other animal. On that cheery note, let's take a biological break, and we'll see you back at 1:30. Thank you all to Johnson & Johnson and to our wonderful two speakers.